How's everybody doing? Morning. Uh,
Morning.
okay. I guess we'll get going. Um, all right. Glad to be home. All righty. So this is a 1-month-old who comes to you with a heart murmur, and this is the electrocardiogram. So what do we think is going on here? What is the diagnosis? Why don't we ask Dr. Kaloff what he thinks? Mohammed, are you still there? I think seems to have disappeared. Okay, so why don't we ask his colleague Vlad? Vlad, what do you think we're looking at here?
Good morning. Um, let's see. Looks like a regular rhythm, tachycardia. So left axis deviation, and the QRS is a little wide. Um,
What do you make of the PR interval?
looks a little long, but I'm trying to find a good one. I guess in B1 I can see nicely. So long PR, left
Long
axis.
PR? You think it's long?
I think so. Let me see.
What about in lead one?
Is it is it double humped like a LA enlargement type of P wave?
Um, well, I don't know, but I thought this was an example of pre-excitation. I might be wrong, to be
Oh,
honest,
I see.
but I think it is. Like if you look in lead ABL, right? P wave kind of stops with the onset of the QRS. I agree, in some leads it doesn't appear that way. But so what would you do if you saw this ECG? So baby comes in, you before the day before clinic, the echo lab wants to know, is this a straight to echo or is this not? You decided you wanted to see the patient first. So you see this electrocardiogram. So what would you get an echo on this patient or not?
I think so. I think uh, yeah,
Uh,
I think
yes.
like yes, because there's just one. It's just a little unusual in terms of there's being a left axis, and also I'm just looking at the T waves. They're also all upright, so that pattern is a little weird for a 1 month old. I expect them to be inverted. So
Yeah. I think this is WPW. I might be wrong, but we never know for sure. But I think in a number of the leads, the PR is pretty short. Um, but I'm not 100% certain. I mean, certainly when you see an ECG with this type of strangeness with a wide QRS and all, of course you would want to get an echo because this could be, well, of course it could be WPW, but it could also be a demonstration of could be a demonstration of some kind of cardiomyopathy or something like that. So when you see a patient, the first thing to say is anybody who's under a month of age who has a murmur deserves an echocardiogram. Just because the incidence of congenital heart disease in a murmur in a child that young is very high. I don't know exactly what the number is, but I'm going to guess it's in the range of 20 or 30%. So as opposed to, say, a 5-year-old where it's probably, 1% or 2% or 5% or something. So the bottom line is a young patient murmur, you would do it. This ECG is certainly at AB normal enough that it would warrant an echocardiogram to figure out what's going on. I do think this is probably WPW. I'm not 100% sure. I certainly recognize that in some of the leads, the PR looks a little longer, but I actually think that the PR is short. I think the P wave is kind of running right into the QRS. And I'll just skip to the chase. If it is WPW, because there is a very deep because it's a deep delta in two, that would be consistent by most by most algorithms to be in the coronary sinus, which is a very difficult area to ablate in adults and children. Um, but yeah, we definitely get an echo here. Okay. Alrighty. So this is a 6-week-old with complex congenital heart disease who's identified. Fellow is just doing their due diligence and is on call and is on service rather, and in the morning sees this tracing in the neonatal ICU, doing their review of tele and sees this. So, question is, what do you think the diagnosis likely is, and what is the you know what do you want to do about this? So why don't we ask Dr. Marshall what she thinks?
Hey, good morning. Um,
Oh.
so do we have like, I mean, obviously what you see just on this snip here is that we're going 6 weeks old. We're at a rate of 255. So, and the it looks narrow complex to me on here.
Mhm.
Um, is this pre-surgical, post-surgical?
Um, this is a patient who had surgery and is now back in the NICU for recuperation and rejuvenation.
Okay. And then do we have like a tele like vitals in terms of looking at like the overall trend of it and like is this kid having it otherwise? Like just trying to appreciate if there's like a sudden um
I believe the
onset.
answer to your question is in the tracing, and so I will not answer that question.
Well, I see the sudden stop, but
Okay, well, things that stop sudden, as let me give you a little rule of EP. If things stop suddenly, they usually also start
start
suddenly.
suddenly. So, I mean, I agree with that statement, but wanting to look
Okay.
further. But okay, so we'll say that it's sudden onset and sudden offset
I will
then.
say this. I will say this, and this is honestly, it's a very important point. Maybe the only important point we reviewed today. In my experience, particularly in neonatal ICUs, and I don't mean this in any way to disparage the Mount Sinai NICU, because this has been true in every single NICU I've ever worked at Columbia, at Montefiore, even at Boston Children's Hospital. It's fascinating to me how often, if you review tele on your cardiac patients in those types of units, you identify episodes of tachycardia that were not recognized at the bedside. Now, I don't mean in any way to disparage neonatologists or neonatal nurses. I think the truth is they're very, very, very busy. And of course, we know that babies' heart rates are very fast in general, normally. And so I think that although I think we would all agree that 255 is virtually never sinus rhythm in a human being, the difference between 255 and 220, which could be sinus tachycardia in a newborn, ain't that big. And so, I'm not suggesting that like all NICUs stink. I'm just suggesting that it can be really hard in a NICU for them to recognize this, especially if it's a short episode. So it is always worthwhile reviewing the tele, particularly in NICUs, because it's fascinating how often you will find, you'll ask the bedside folks, how did the baby do last night? Somebody, let's say that had SVT, and they'll say everything was fine, quiet night, and then you go and you see like 4 episodes of this. So just keep that in mind. But anyways, okay. So what do you think's going on here, Dr. Marshall?
So, given that we see the rapid stop or rapid ending of it,
Hmm.
and going back to what looks like sinus rhythm, would say it's some type of reentrant tachycardia. The kid's blood pressure you can see also on there doesn't like it.
Yeah, that's right. Doesn't seem to like it at all. So now I'm going to complicate this and say this is let's say this is a shunted patient. I'll make this up with tricuspid atresia. So, first of all, what do you think is the most likely mechanism for this SVT? So you said it's a reentrant arrhythmia. I agree with that statement, and you're basing that on the fact that it's suddenly terminated. And presumably you can go back on tele and see that it suddenly started. what is the most likely mechanism, do you think, then?
Um, by what I know about reentrant tachycardia, would know that AVRT is most common.
That's right. Orthodromic reentrant tachycardia would be the most common. And what would be the second most common?
AVNRT nodal.
That's right. Those two would constitute probably 95% of SVTs in small infants. Now, I'm going to complicate this more. This patient was known to have SVT and was on propranolol when this occurred. Um, what would you do about this?
Do we know the dose?
Yes, the dose was 4 milligrams per kilogram per day divided Q6.
And I know you're not going to let me look at the overall trend, but this is the only time the kid had it, or is the kid having it all the time, or what? Like, I mean, obviously the
Child
kid being
had
complex,
This
but
was a 1 minute episode and was the only episode that occurred that night.
since being on the meds, then.
What's that?
Like, you're saying this is the only episode since the kid's been on medicine?
It's the only episode since medicine. The patient's been on medicine for about a week, and this was the episode that you identified. This 1 minute episode occurred last night.
I see. So if it was a kid who didn't have underlying heart disease and it was just one episode, I would, I mean, it's a minute, so it was sustained. But what I mean, so you could argue that you should change it regardless if it was sustained. But if a kid was
Sure.
having short blips, I probably, and the kid did not have underlying structural, like single ventricle physiology, which is what you're hinting at, that the kid has heart disease. But if the kid is somebody with complex heart disease, would want to change it up, or add other medications, because I really don't want him sitting in SVT. So, I mean, if he's on to already propranolol of 4, it's a pretty decent dose. You could add like digoxin on top of that.
Now, that would be one option. Any other options?
Yes.
Okay.
um,
Why are we if this child did not have congenital heart disease, what would you do? Would you change up the meds or leave it?
it depends on, I think it depends on what the kid's trajectory is. If they're gonna be there for a long time and they're gonna be on telly and we're watching it, like we're able to review the telly, I would maybe watch it to see. And then if, but it, again, it is a little borderline to me because they were having sustained if it was for a minute. But you do have like the benefit of them being there. And if they do it again or have more episodes, you could add it
Yeah, I
or
agree.
adjust the medication regimen.
Yeah, I agree completely with you. I think that in the NICU, particularly, especially if you have a premature infant who might be there for 2 or 3 months, it's not unreasonable to observe that patient and not make any changes on the theory that you're not going to lose anything by watching, and you're in a monitored area, and it could resolve. It's not something, for example, you can do with a full-term infant who's going home, but in someone
Yeah.
who's going to be in an ICU setting for a couple of months, it's certainly not unreasonable to say, well, I accept this patient has a pathway or has AVNRT, but I also recognize that I have 2 months to see if it resolves. We're in a monitored setting. If the baby gets into any trouble at all, can be instantly managed and treated. So yeah, that's not unreasonable. But in someone who has complex congenital heart disease, the point we're trying to make, obviously, is that they're going to be more hemodynamically embarrassed by tachycardia than the average person who is otherwise has a structurally normal heart with normal function. So, in the event that you have somebody with this who has complex congenital heart disease, in general, we would be a little bit more aggressive. Interestingly, when I was trained, they were a long time ago. My mentors were very aggressive. They would put somebody like this on amiodarone or sotalol or flecainide, and those are all very reasonable options. But I don't know, for some reason, I got into a conversation with John Triedman not long ago about this issue, and he was explaining that, sometimes they just put them on propranolol and they're not as aggressive anymore. I couldn't really get a good sense about why, other than that I think I think probably what he was trying to say was that in general, when we think about babies that come into the emergency room with a tachycardia-induced cardiomyopathy with terrible function, generally speaking, these are infants when the family had no idea that their child had SVT. So the child was in it for a very prolonged time. It's extremely unusual in my experience with even a semi-decent parental pair or parental unit that you see a baby come in moribund from SVT, whose family was aware that the child had it. So it's not unreasonable to do something simple like you suggested, Molly, and just add digoxin in this setting. And a lot of people have had great success with that combination. Some would say I probably would not do that. I probably would completely change course and maybe start something a little more aggressive like sotalol or maybe even amiodarone. Because a short course of amio, 6 to 12 months, carries very little risk. Amiodarone, you remember, one of the big features of there's two really good features about amiodarone. The first is that it is extremely unusual to be pro-arrhythmic. It's one of the least pro-arrhythmic agents around, so that's a good thing, obviously, as opposed to something like flecainide, which has a high chance of that. And the other thing that's nice about amiodarone is it's a once a day medication. And I can assure every single person on this call that when you have a baby with SVT, you will be asked more than once in your career by the parents, does it have to be 3 times a day? So giving a med once a day is very nice. I remember reviewing a paper from Ireland where the first line therapy for SVT in Ireland at that time, this is about 15 or 20 years ago, was amiodarone. And it's because it's easy for parents to administer, carries very little risk in an otherwise healthy child for short-term treatment. So there's different ways to manage this, but I agree. I would not leave a baby with complex congenital heart disease who's having 1 minute episodes of SVT. It's too dangerous, in my view. Would treat this. Even if the child was staying in the NICU, I would probably still treat it because, invariably IVs fall out, etc. Also, you never really know when someone's going home, right? So many times we think a patient's going to be there for another 3 months, and you round in the morning, and we're getting ready to discharge. So probably good to get our affairs in order, as it were. Okay. Any questions about that?
You were saying in terms of you were talking to people where you trained and
Yeah.
they would do first line, not like you're saying they would do something like I feel like we usually do propranolol
No,
here.
no, they would use propranolol. What I'm saying is that, like, in someone with complex heart
I
disease, they would usually use more potent stuff. They
As
would,
first line though is my
as
question.
first line, yeah,
Okay.
first line, they would say, the risk of SVT in this particular, hypoplast, for example, is very high, and of
Just to like nip it in the bud, I guess.
right, and so we
Yeah.
should really slam it hard. I actually agree with that. As they say, you're a victim of your training, but that is really what I believe. I feel like that's a dumb reason to die when you have so many other complex heart problems. So, and the risks of being on something like amio or sotalol or even flecainide are relatively low, and the risk of SVT is pretty high in that patient group. Okay. All right. This is a 10-day-old who is 3 days after an arterial switch operation for transposition. What is the diagnosis that we're looking at, and what would you do to treat this patient? Let me ask Dr. Ivana Capon of the Critical Care Consortium.
Morning, how are you?
How are you?
Now sorry.
that she's back from a neonatal meeting of some sort.
Yes, thank you for that. All right, so looking at this rhythm strip, so this is a 10-day-old post-op day 3 from arterial switch. This kid looks overall bradycardic. The rate definitely looks, let me just calculate it there. like a rate of 60 or so, which is of course bradycardic for this patient. But what you can appreciate is you see P waves that conduct, but then it looks like you see another P wave coming in just shortly thereafter the QRS um, that is blocked. So I think this looks like a patient with blocked PACs in a bigeminy type pattern.
So that's correct. I agree with every single thing you've said. How would you summarize that description? What would we call this?
Atrial bigeminy.
That's correct. This is atrial bigeminy. So what would you do about this? Or do you need to do anything about this?
If there's no hemodynamic consequence for the patient in the ICU and we have monitoring, I don't think we could watch and just see what happens. And again, as Molly mentioned earlier, depending how long the patient's expected to be admitted for, I mean, they're only post-op day 3 from a switch, so I imagine they have a good few days left. I'd probably just watch for now and see if it resolves and make sure all my lines were removed or just not irritating any kind of atrial area. So making sure that IJ was out or any kind of UV line. And then if he or she remained in this rhythm or had some hemodynamic consequence, which I wouldn't really necessarily expect, you could consider starting an agent such as a beta blocker. But again, I don't really think I would do anything at this point.
Okay, I agree with that. I think that this comes up not infrequently, particularly in newborns. And general rule of thumb is that you probably don't need to treat this. But if, it does happen though that sometimes it can persist for a couple of hours at a time, and sometimes the bedside folks get nervous about this. And so it's not uncommon that we are forced to treat it because of concerns at the bedside. There any minor change in the clinical status of the patient this is impugned as the cause. And so I agree with you. As strange as it might seem to treat a bradycardia with a beta blocker, you might consider using a beta blocker or digoxin. I would try not to get any more aggressive than that to manage something like this. But so my first choice would be no therapy, as you suggested, and my second choice would be something simple like a beta blocker. Okay. All righty. This is a 2-month-old. And can you see the top of that EKG? I can't see it on my screen, but it says atrial flutter is the pediatric.
Yeah, you can see that.
Okay, I just can't see it on my screen. So do you agree with this diagnosis? And how would you treat this acutely and chronically? May I ask Dr. Mukhopadhyay what she thinks?
Good morning, Dr. Pass. So I'm looking at the rhythm strip at the bottom, the V1.
Mm-hmm.
I see a narrow complex tachycardia,
Yeah.
and I'm looking for P wave. I don't think there is a P wave unless it's like hidden. So it's not very obvious that there's a P wave. So this is probably some form of a reentrant tachycardia, probably like an ABRT. And I don't think this is atrial flutter. I don't think so.
And one thing that's curiously absent from your otherwise excellent interpretation is the heart rate.
Oh, so yeah. So it's around it's 1 block, so it's like around 300 beats per minute.
Right. So if I said to you, when I was a fellow, we did not have smartphones. I hate to say that, it makes me sound very old. But we did not have smartphones. And so when I was the EP fellow, and if you had been the first year categorical fellow or second year fellow, and you were calling me as the EP fellow on call, you would have to describe the electrocardiogram to me. And I would have to, in my mind, imagine what it looked like. But so, when somebody tells you that you have a narrow QRS tachycardia at 300 beats per minute, even without looking at the electrocardiogram in a newborn, what are you thinking about, Katoki? What is the differential in your mind? So you said it's likely not atrial flutter. What would the heart rate normally be in a baby who has atrial flutter at this time as a newborn or 1 month old, 2 month old?
Um,
Would it be
yes.
300?
It'll be around 300 to like 400, something like that.
Well,
Like faster than this.
that's what the atrial rate would be, and it could even be higher, right?
Yeah.
But usually atrial flutter in newborns or in very young infants, the ventricular rate is fast, but not this fast. It's usually in the like 200 or 210, 220 range. Okay. And there's usually like 2 to 1 or 3 to 2 or some kind of pattern of that nature. So it's very unusual to see atrial flutter with a ventricular rate of 300. So the point I'm trying to make is when you see it that fast, almost always it's ORT or AVNRT in a newborn or in a very young infant. It's not flutter. Now, if it were flutter, you would also, of course, if you were worried about flutter, you'd be looking to see if you could see more than one P wave for the QRS. I think you could make an argument here that in lead 3, that there's a suggestion of something following each QRS on the T wave. It's hard to see in all of the beats, but I think you guys have heard me say that a number of years ago, I did a study with a fellow, and what we did was we took like 100 cases where we had performed ablations on the patients, so we knew the mechanism of their SVT. We took a ECG of their clinical SVT. We cut the EKG up so that we had 12 separate, panels for each of the leads of the ECG, and we had two electrophysiologists review them and decide based on them what the mechanism of SVT was. And what we determined was that if you used a combination of V1 and lead 3, that combination got you the right answer about 90 to 95% of the time. So you always want to look at lead 3 and V1 when you're thinking about SVT. And this is one of the rationales for that study was that we always had the impression that on in ICUs they typically project lead 2 on the monitor, but actually lead 2 was lousy at identification of SVT. We always thought based on this that either V1 or 3 should be displayed, but never really caught on. But it was a nice little project, a sort of a simple project. But so when you see it at 300, it's almost certainly ORT or AVNRT. So how would you acutely manage this, Katoki, and how would you chronically manage this?
Um, so if I would like to do an echo to see what the function is, because I don't know how long this has been going on.
I understand that, but the patient looks a little peaked, not to always want to think about the patient first. I
Okay.
agree with
Uh,
you that I
yeah.
also would like to know what the echo looks like. But you have a patient, I would make the argument that there's never a scenario where someone's heart rate is 300 beats per minute that you should be asking for an echo first.
Okay. So I would try to break it using vagal maneuvers,
Mhm.
and if that
What
doesn't,
vagal maneuvers would you use in this 2 month old?
I would start with ice on the face and see if that works. If not
Okay.
that, then I'll do some rectal stim. If that doesn't work, I would quickly do and put some adenosine and see if that breaks.
Okay. So I don't remember adenosine being listed amongst the vagal maneuvers. You put
No.
it in there as if it was one of the vagal maneuvers. You could also do a knee chest, right?
Yeah.
I would probably try that before I would stimulate the rectum, honestly. But yeah, okay. So you break the tachycardia, the child's in sinus rhythm. And then, of course, we've already discussed this morning, there are many different options for treating this arrhythmia chronically. Would you treat it? I mean, so now I would get your echo. Why? And I would get it for the reasons you described, which is to assess the function. And so what? So the function is mildly depressed. So you start the patient on a beta blocker, And very importantly, you have to have a long conversation with the family about the signs and symptoms of SVT. And this is an interesting question, which is, do you send the patient home with a monitor? How do you manage the family's surveillance of tachycardia? So of course we would start a med, we would watch the child, confirm that the patient was doing well on the medication for a few days, no more SVT. And there's this is an issue of style in terms of what a cardiologist would recommend to a patient. My personal bias is I usually recommend if a family seems, moderately competent, I would recommend that they buy a nurse's stethoscope, which you can buy in a pharmacy for about $15. And I teach them how to measure an apical heart rate. Um, and what I normally recommend is that families check the heart rate twice a day, morning and night, on the theory that it takes roughly 24 hours to develop a tachycardia-induced cardiomyopathy. So if you're checking it twice a day, it should be very unusual for a patient to have an episode of tachycardia-induced myopathy. Obviously, if there's concern in the middle of the day, they can listen other times. Some families prefer that owlet sock-like device. Some families have pulse oxes at home. It's also not unreasonable not to measure it at all and to have the family just be instructed regarding the signs and symptoms of SVT in babies. But I personally think it's reasonable to have a family check it at home in some manner. I don't love the idea of putting them on a monitor because I feel like it makes the family think you're more worried about it than you are. It's also very cumbersome in daily life to have that thing all around, mostly because it's going off inappropriately a lot of the day and can cause a lot of anxiety. And I also think, to me personally, the idea of telling a family that they have to check it twice a day has the benefit of suggesting to the family indirectly that you're not that worried if it's something that can be checked twice a day rather than all the time continuously. So that's my own personal bias. There's no right answer to this. Some people, some doctors even send patients home with home telemetry. As you know, the Zeo patches that we have, there is a Zeo patch that actually is a telemetry patch, and it comes with a phone and there's a central station, so you can actually send people home with home telemetry as well. But again, I generally don't prefer that if I don't need it because I just think it suggests a level of fear and concern on our part that's great. And I would make the argument that if you really think someone needs it at home, probably they should not be at home. All right, any questions about that? Okay, so key point here is heart rate of 300 almost certainly always is going to be SVT in a newborn or a very young infant, and it almost never is going to be atrial flutter. There's no nevers in medicine, but it's close to never. So, all right, thanks, guys. Hope you have found that useful. I will see you at sign out in just a little while.
Thanks.
Thank you.
Have a good day, everybody. Take care.